Great. So now that this is for posterity, I will say hello. My name is Jesse Suter. I'm the director of the Center on Disability and Community Inclusion, and I use he, him pronouns. And I'm excited to introduce our presenters for the second session in our Scope Vermont training series. Our presenters today are Megan Mitchell and Tony Fallon, both with the Vermont Department of Health Division of Alcohol and Drug Abuse Programs. Megan Mitchell joined the Health Department Division of Alcohol and Drug Programs in 2016. Prior to coming to VDH, Megan worked for the Vermont Department of Health Access in the Medicaid program. And prior to her state service, she worked in community mental health and substance use services, and for an agency focused on intimate partner violence. Tony joined the Health Department in 2010. And prior to coming to VDH, he had almost 20 years of experience in urban and rural community mental health and substance use disorder treatment, including medication for opioid use disorder. So thank you to both Megan and Tony for joining us today. And I turn the presentation over to you.
Thank you, Jesse. Tony, unfortunately, is having some technology issues, so he may or may not get to speak up during the presentation, but I know he appreciates being here. So we're here to talk about trauma, substance use disorders, and recovery. You can go to the next slide. So we're going to go over just an understanding of substance use disorders. We're going to talk about stigma as it relates to substance use disorders, and then we're going to talk a bit about treatment options. Next slide. So the American Society of Addiction Medicine, ASAM, as it's often known, defines addiction as a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction, substance use disorders, use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. So that is a lot of words that I usually say simply describes that substance use disorders are complex. There's not a simple, easy answer to why someone might develop a substance use disorder. It's complex. We can go on to the next slide. So key takeaways. Substance use disorders are chronic brain diseases, but they also have the possibility and the likelihood, quite frankly, of remission and recovery. They're not moral failings. They're not people's choices and bad decisions. They are healthcare conditions. And like most healthcare conditions, there are treatments that can be very effective in helping people recover from those healthcare conditions. And like healthcare conditions, people have recurrences of their symptoms of their diseases. So like folks with asthma, there are times when their asthma is worse than others, when they're having to use more of their medications and lifestyle changes to manage their diseases. Substance use disorders, same thing. Prevention efforts and treatment for substance use disorders are typically about as effective as they are for other chronic diseases. If you look at relapse rates or symptom recurrence rates for things like asthma, diabetes, high blood pressure, they're very similar to relapse rates or lapse rates as they're described in substance use disorders. So you can go to the next slide. So when an individual is using substances, the brain typically gets flooded with dopamine during the use, and it activates that brain's reward circuit. So you feel good when you use the substance. Because you feel good, it reinforces using the substance and you want to use the substance again. the more that you're using the substance and getting that good feeling from the substance, your brain tries to compensate for that flooding of dopamine by reducing the amount that it is producing naturally. So not only does the feeling good of the substance reinforce the using of the substance, over time, your brain gets used to kind of that artificial jolt of dopamine and produces less. And so when you're not using the substance, you feel even worse than you did before starting to use the substances. I was a big coffee drinker at one point in my career, and certainly I think anyone who has used caffeine to excess over their lifespan knows that coffee, feels great when you're drinking it. You feel energized, you feel good. Over time, you realize that, if you stop using that caffeine, you get headaches, you feel kind of lousy. So the initial reinforcement of coffee makes me energized, makes me focus, then gets reinforced and replaced by the if I don't have coffee, I'm really, really cranky and people don't want to be around me. So that's a very kind of real life way of talking about tolerance. You drink your coffee, all of a sudden you're drinking 5 cups of coffee instead of 1 cup of coffee to feel the same kind of energy and awakeness. And if you stop drinking coffee, you get headaches, you feel lousy. You can go to the next slide. So this is just a visual to kind of demonstrate specific to opioids, what's happening in your brain. And so on my left side, which hopefully is the left side of the screen for you all, it shows kind of a typical brain. You've got the endorphins going, not everything's full, kind of just status quo. On the right side of my screen, where the little red dots are, that's showing where you're putting opioids into your system. All of a sudden, you've got much more stimulation of those brain cells, and your dopamine is just spiking all over the place. Next slide. Here we go. So there are some risk factors that are generally expected when talking about someone's risk of or likelihood of developing a substance use disorder. And unfortunately, you're going to see addiction throughout this, and I will typically talk about substance use disorders because that's what this is specific to. But addiction is kind of a word that is still existing in a lot of the national information that you see. So when thinking about substance use disorders, we have our biology, we have our genes. We do know that risk factors for developing substance use disorders, depending on the substance, are anywhere up to right around 40 to 50%. So, if someone has a parent who has an alcohol use disorder, and that genetic risk is could be passed down to that individual's children. We also know that substance use disorders do tend to co-occur more or less strongly with some mental health conditions. And so if someone has a mental health condition, then that also, on the biology side of things, can make them at higher risk for developing a substance use disorder. We also have the environment that we grow up in. And we talked about a bit about this last week when we talked about the social determinants of health in connection to substance use disorders. But our community attitudes, our functioning in school, whether we are raised in a household where there are substance use disorders, that all of those pieces of our environment can contribute to our risk of developing a substance use disorder. And I try to be careful to say risk because these are not causal. These are not um, predictor is not the right word, but if you have genetic vulnerabilities, if you have environmental vulnerabilities, you are not guaranteed to develop a substance use disorder, but these are things that can increase our risk. And then we roll into the use of substances and the impact those have on our risk of developing substance use disorders. So the age at which someone starts using substances, the way in which they use the substance, can all increase or decrease your risk of then developing a substance use disorder. So if someone is starting to use substances at 12 or 13 versus 21 or 22, if someone is using substances by mouth or by smoking or by intravenous, those are all different ways that can increase or decrease risks of later developing a substance use disorder. So again, key takeaway, it's complex. It's not one simple cause of substance use disorders. So next slide. This is just kind of reiterating what we saw on the last slide. So there are biological factors that increase or decrease risk to developing a substance use disorder. There are psychological factors, so mental health concerns, living in a stressful community or home. And then also the environmental influences, so exposure to violence or trauma, having a parent who has a active substance use disorder, living in a community or going to school where substance use is perceived as the norm, and then just overall social determinants of health, poverty, lack of resources. Next slide. So doom and gloom risk factors. Now to move into some of the protective factors, a little bit more uplifting. So parents and guardian support and monitoring is an incredible protective factor. There are some studies that show that even in a family where there is substance use, if you have one parent or adult in the house, that is a protective factor, even if the other parent is struggling with substance use. Positive relationships, both peer and adult, are incredibly protective when thinking about children's risk for developing substance use disorders. And then neighborhood resources. Do you live in a neighborhood where there are healthy activities for kids to participate in? Is it a neighborhood that takes care of each other and there are parks and other opportunities? So all of these things can help protect kids from developing substance use disorders later on in life. Next slide. One of the big pieces that we talk about in the prevention world for prevention of substance use disorders is how do we get kids to put off their first use of substances for as long as possible. So making sure that brains are as fully developed as they can be before they are being exposed to substances. So there are some targeted interventions with regard to individual risk factors, looking at making sure that families are treated for any kind of trauma issues, that parents are treated for their substance use disorders, that we're addressing homelessness and other pieces of poverty. And then also strengthening protective factors that are available to kids in communities, like making sure there are mentoring programs, availability of positive relationships, that communities are supportive of kids and are providing opportunities that are not substance related for those kids to engage in. All of these things can help prevent the development of substance use disorders despite the complexity of the genetic and the environmental factors that can up the risk. Next slide. So moving on to stigma related to substance use disorders. So when we think about stigma, stigma kind of falls into three different categories. So there is public stigma, which I think most people are kind of familiar with. And that's when the general population, the community endorses stereotypes and decides to either directly or indirectly discriminate against people who are labeled with that particular health disorder. There's also self-stigma, and that's when people with a health challenge or a healthcare disorder, like a substance use disorder, internalize those stereotypes that exist within their community. And then the third type of stigma that we run into is label avoidance. And so when public stigma, the stigma related to having a substance use disorder, impacts the individual with the substance use disorder to the extent that they actually choose not to seek care in order to avoid being labeled as someone with that particular health disorder. And so, I think of this in terms of language often. So thinking about the public, thinking about the words in which we describe someone with a substance use disorder. So there are communities, there are segments of the population who still refer to people with substance use disorder as addicts, or worse yet, junkies. So people then hear this in their communities. And so then they internalize it, and we move on to the self-stigma. So instead of thinking of themselves as a person with a substance use disorder, with a healthcare condition, they start to think of themselves as that label that they're hearing out in the communities. I'm just an addict. I don't have a healthcare condition. I'm an addict. I made choices. I'm getting what I deserve. And then thinking about label avoidance, if an individual is in a community where the language of addiction is you're an addict, that person, if they're discovering that they have a substance use problem or problem with substances, they may choose not to go to their PCP, not to go to a specialty provider for fear of being labeled as an addict. And so they are choosing not to seek out their own health care for a healthcare condition because of fear of how the community is going to label them and discriminate against them. And I do realize I used some provocative language there. I hope I hope people understand it was for illustrative processes, but I also recognize that that was some harsh language to hear. So next slide, please. So this is just a little bit more of a description of what I just talked about on the last slide. So the first line is kind of that thought process of going from public to self-stigma and then label avoidance. And then some more examples of the discrimination that goes along with the stigma and the stereotypes of people with substance use disorders. Again, I think these are probably not things that are unfamiliar to you, but discrimination in employment, in housing, discrimination even from the healthcare system, because they are perceiving that people with substance use disorders are people who are making choices and doing bad things, as opposed to people who have a healthcare condition that is in need of treatment. Next slide. So part of what we can do to address stigma is to think about our own language. And again, I purposefully used some language that was stigmatizing to try and illustrate the public self and label avoidance concepts, but these are some more words that continue to be common in language, and their alternate language that is less stigmatizing. So instead of referring to people as addicts, it is a person with a substance use disorder. Instead of talking about clean or dirty with regard to urine drug screens or toxicology screens, talking specifically about what you are and aren't seeing in those particular screens. And then instead of talking about, a former addict, using that person first language, so a person in recovery or a person in long-term recovery. And then one that's interesting, and quite frankly, the language is evolving very quickly, is when you're talking about what used to be called medication-assisted treatment, now referred to as medication for opioid use disorder. It is often described as opioid replacement or maintenance therapy, but looking at it as a typical medication that might be used in a healthcare condition like medication for high blood pressure or medication for asthma. And I do see a question in the chat. Where do pharmaceutical companies and overprescribers fit into all of this? And I'm hoping that person could give a little more context to the question to make sure I'm answering what they're looking for.
Yes, I just, in a couple of families that I've worked with, they started with a knee surgery or something, or chronic back pain, and they had never had any history before, and things just got really challenging from then on.
That's actually a great question, Mary, and I appreciate that. And that actually helps illustrate the it's complicated point that I made at the beginning of the presentation. So everyone, because we all have these different risk factors, someone may be more or less vulnerable to a particular substance. And so when I think about, we talked about this at the last presentation last week, in looking at individuals with labor-intensive jobs or people with injuries who are prescribed opioids, not everyone who gets prescribed an opioid ends up with an opioid use disorder. So it's the interplay of all of the particular risk factors for an individual, plus the substance that gets used. And quite frankly, opioids are really good at their job. Opioids in the short term make you feel really good and get rid of pain. So they're incredibly effective at working on your brain and reducing pain. And so, I don't know the particular families that you work with. You would have to think about what the particular risk factors that might be for that individual. Quite frankly, it could even be just genetics way back in the family history that the person may not even know of. And then, quite frankly, a really effective medication gets introduced to that person, and the risk factors of the genetics, the risk factors of their environment, coupled with a super effective pharmaceutical acting in their brain, can result into that substance use disorder.
Great, thank you.
You can go to the next slide, I think. So in trying to address stigma, Vermont over the past couple of years, the Vermont Department of Health has looked at creating media campaigns to specifically address stigma and substance use disorders. And we've broken that out into a couple of different areas for the most recent campaign. I lost the word there. So right now, we have a campaign that focuses actually on healthcare providers. And we have one of our healthcare provider champions talking about the his mission and his dedication to addressing substance use disorders as a part of the overall healthcare system, and encouraging other healthcare providers to look at substance use disorders as simply another healthcare condition to be treated, as opposed to something that is, that doesn't fit within primary care or the larger physical healthcare system. We also have a campaign that is focused on employers. And so we have some champion employers who speak about the importance of and the place of people who are in recovery in our workforce. And there is a link, and I think you guys will be able to get the slides to be able to get more information about the health department's stigma campaigns. You can go to the next slide. I'm trying to keep an eye on the time, Jesse. I'll go quicker. So the National Institute of Drug Addiction clearly says that treatment is a long-term process that may involve multiple interventions and regular monitoring. And ASAM talks about treatment for substance use disorders as being on a continuum and organized into different levels of care. Next slide. So ASAM looks at the levels of care from prevention or early intervention all the way through hospital level of care. And so you can look at outpatient services, which could be individual or group counseling. This could also be receiving medication for opioid use disorder at a hub or spoke. There's intensive outpatient programming, which is still you're living at your home or at a recovery residence, but you're receiving services in the community, just more of them. And then residential care, which would be receiving services at a place that you live, and then all the way through services at a hospital. So next slide. And then NIDA looks at the different components of comprehensive treatment. And again, this is old language, drug abuse treatment. We would talk about treatment for substance use disorders. And so you have in the middle of that circle, in the white boxes, what would typically be thought of as treatment services. So thinking about group services, case management, counseling, intakes, perhaps pharmacology, pharmacotherapy. And then around the outside are all the adjunct things that people need to support them as a part of their treatment and their recovery journey. So housing, transportation. If you don't have a house, it's really hard to stay engaged in healthcare services. Making sure that you have access to education and job training, making sure that you have access to other healthcare services, either for mental health or for physical health. Making sure that you have childcare. Again, if you're caring for small children, it's really hard to engage and stay connected to treatment services. Next slide. So this is going to be, I'll stay fairly brief on this. So counseling really focuses on your thinking and then your actions related to substance use, and making sure that you have the skills to be able to engage with and stay healthy in your recovery. Case management is really about connecting people to services and supports that they need. That's all of those social determinant pieces that can either support you or get in the way of you staying connected with treatment. Next slide. So in Vermont, in the midst of a pandemic, the Vermont Department of Health stood up what we refer to as VT HelpLink. And that is a website and a call center that is a one-stop shop for resources and referrals for treatment and recovery in Vermont. And you have the link there. Next slide. Medications can be used as a part of treatment for substance use disorders, like they can with many other healthcare conditions. So medications are often used in combination with counseling and other pieces of a comprehensive treatment plan. There are FDA-approved medications for opioid use disorder, alcohol use disorder, and tobacco use disorder. I know opioid use disorder is what people tend to think of when they think about medications for use disorders, but alcohol and tobacco also has some very effective medications. Medications can be used to help reduce cravings for substances. They can provide overdose prophylaxis, so help reduce people's risks of overdose. And medications can really help people be comfortable enough with their cravings and or with any kind of withdrawal symptoms to be able to better engage with other aspects of their treatment. Next. So methadone, buprenorphine, and naltrexone are the common medications used for opioid use disorder. So all of them, to some extent, blunt or get in the way of the euphoric effects of the opioids. Naltrexone is available through any prescriber. Buprenorphine is available through prescribers, especially in Vermont, through our spokes. Methadone does have to be dispensed through an opioid treatment program. We call them hubs in Vermont, and that is due to federal law around that. Next slide. I think I'm close to done, hopefully. So opioid use disorder medications, methadone fills up the receptor that the opioid sits on. And so basically it kind of is like a cap in the receptor and keeps the other opioids from getting in. Buprenorphine is like a cap, but not as quite tight fitting as methadone. So it does a pretty good job of keeping the other opioids out, but it doesn't fill up the receptor to the extent that methadone does, in that buprenorphine, you're not really going to get euphoric effects if you take more and more buprenorphine. And then naltrexone kind of sits over the top of it. It's almost like a cover to the pot, and keeps the opioids from getting into the receptors. And that's a super simplification of the medications. Next. Vermont has a number of strategies that we're looking at to hopefully reduce harm and prevent overdoses. So Vermont does have a number of syringe service programs that link people to healthcare resources, link people to treatment, do testing for infectious disease, and provide clean syringes and injection equipment to reduce people's risk of contracting and passing on infectious diseases, or of just getting healthcare conditions related to having dirty needles, like cellulitis or endocarditis. So CDC estimates that about the SSPs provide about a 50% reduction in HIV and Hep C incidences. Newer users of SSPs are 5 times more likely to enter treatment and 3 times more likely to stop using substances than people who don't use those programs. Next slide. Yes, there is a list of needle exchanges, and I can provide that on this slide. So the link to the syringe service programs is right here on the slide. We also have a website, a web page that speaks to our other overdose prevention activities, including our Narcan distribution. Next slide. I love it.
So this is Jesse. Megan, that is the final slide. So I think people wanted that link, so we can leave it up.
Here we go. And I'm not hopefully too over time. I was trying to move quickly.
No, thank you, Megan, and thank you for responding to the questions and monitoring your own chat. That was wonderful. I'm the only other thing I'm seeing in chat is Jennifer sharing that Vermont Cares as well. And Jennifer, I don't know if you're saying that they have a list of the sites or they provide services that you wanted to highlight. You can go ahead and unmute yourself if you want to.
Yes, I'm sorry.
No
yeah, so I can put the website in the chat. It looks like they provide a whole bunch of services. They provide storage services, HIV and Hep C testing, overdose prevention, and wound care support.
Yes, and Vermont Cares it does have several of our SSP programs, so they're a great partner with Vermont Department of Health.
Great. Well, thank you everyone for your questions and sharing resources in chat. That was really helpful. Many of you were faster than I could be in chat, so that's great. That's one of the main goals of this is to support each other. Megan, thank you so much for presenting today. Tony, thank you also for being there. I know we had to reconnect you maybe a dozen times, so thank you for your persistence, even if it was behind the scenes today. Really appreciate your participation.
Thank you.
So we and there again, so there were several questions in the chat about getting the PowerPoint. We're going to post the recordings and the PowerPoint onto our website once we have the captioning all fixed with the videos. So hopefully we'll get those out, and we'll email everyone who's registered once that's available. All right. So now we're going to transition to our case presentation today. And as a quick reminder, the case presentations must remain confidential. So as we're presenting them, or as they're being presented, and as we're talking about them, please, if this is a person or a family or any individuals involved that you're familiar with, don't use any proper names so we can keep it confidential. Along those lines, I'm going to stop the recording, and then I'm going to introduce our case presenter.